Thank you very much, and welcome to all to this session in the symposium. And it's my pleasure to introduce Mary Dahm and her co-author Carmel Crock, who are going to talk about a pragmatic look at hedges in the diagnostic assessment, communication of uncertainty and diagnostic error. So over to you, Mary.
I'm just going to share my screen. Thanks, Susie. I don't think I talked to Carmel, but Carmel is actually working in the ED, so I don't know. She might pop in, she said. If it's quiet, if not, she wished me all the luck and said I'd be representing us both well. Because I think some of the people in the audience today probably haven't heard a lot about diagnostic error and communication and how that all relates to each other. But just to give you some sort of background and short statistics, there's up to 4,000 deaths that are due to diagnostic errors in Australia every year. Just to put that in perspective a bit, there were about 1,200 deaths on roads in Australia last year, so that's quite substantial if you compare it to that. And then there's a number of communication related errors in that, usually said to be between 25%, but all the way up to 80% in some cases. So the 25% in the data in Australia is relatively small. That comes from malpractice claims and lawsuits against doctors. And then uncertainty is basically pervasive in medical care. Like it's everywhere, and it's really critical in the diagnostic process. And it's because if you look at it, for example, in a GP setting or in emergency, you want to go, most patients go because they want to know what's wrong with them. But oftentimes doctors can't really say what is wrong straight away, because diagnosis is an actual process that oftentimes takes time and doesn't really have a set clear point. So interpersonal communication within that field is quite interesting, because the diagnostic error research has really focused on organizational communication or informational communication. So looking at how is data such as laboratory results or referrals or things like that communicated from point A to point B, so just between doctors mostly, and using healthcare technologies. But they haven't really looked at the interpersonal aspect, and that brings me then back to what we've looked at from a linguistic standpoint. Not just we, but the linguist world has looked at diagnostic statements before, and they've sort of said what a diagnostic statement or a diagnostic utterance actually does. And it's basically naming, describing, and providing an explanation for the patient's problem. So to this, and that's sort of established in the linguistic literature, but to this I would like to add that fourth part of sharing a working diagnosis and a level of uncertainty, which, for example, could be something like, well, look, I'm not 100%, but I think it could be either this or that. So, but have 4 parts to your diagnostic statement. Backtracking a bit, why is this also important? The importance is that in 2015, the National Academies in the United States, they published a big report on diagnostic error exclusively. There was a really big report by the same organization about 12 years earlier than that, called To Err is Human. It was all about medical error, but it didn't discuss diagnostic error at all. So this 2015 report sort of tried to catch up on the diagnosis part of things. And what I find really interesting here is that they didn't just have a clinical part of their diagnostic error definition, but also a communication part. So it is even a diagnostic error if you get the diagnosis right, but you do not manage to communicate that explanation to the patient successfully. And that relates to diagnosis, to uncertainty in diagnosis, obviously, because if you can't relate that uncertainty, does that also qualify as a diagnostic error? So brings me back again to what actually is uncertainty. So how is that defined? And there's 2 ways to define it. So there's a doctor-centered definition, basically is the doctor's perception that they're unable to provide an explanation. versus sort of the patient-centered definition that anything that anyone says that indicates uncertainty to a patient is uncertainty. So there are different ways to look at how uncertainty can be expressed. But what has been done on uncertainty sort of shows that it has huge effects on the doctor-patient relationship, but also on actual health outcomes. So it can affect how patients are trusting in their doctor, what confidence they have, whether they adhere to anything in terms of treatment and management that the doctor told them. But it also can affect sort of how much they are involved in shared decision-making and informed consent and things like that. And then how is it expressed? Well, there's different ways to do it. It can be verbal or non-verbal. It can be just gestures like a shrug or flipping through charts randomly. It can be really direct as to say, I don't know, even though looking at it from a pragmatic perspective, some people also classify I don't know as a hedge. We won't go into that much detail today, but there's the obvious sort of classic difference that you could think between something directly saying, I don't know what it is versus maybe hedging either lexically or grammatically. And I'll get to some examples later on. Obviously, then it's also a question of who are you talking to or who are you writing to, because you can express uncertainty in speaking with your patients, their family, or with other clinicians, but also in writing. So in patient discharge letters and referral letters, in reports of x-rays and things like that, there's a lot of uncertainty present in these sort of different modalities. What I found most interesting when I started to look at this was that apparently it's really, really hard to measure. So this is a quote from a study by Gordon and colleagues who looked at audio recorded interactions, and they were trying to code indirect expressions of uncertainty, which they defined as various hedges. And they said they are probably the most common form of verbally expressed uncertainty, but they did not proceed in their analysis in looking at them in particular because they were unable to code them reliably within their team. And I thought that was quite fascinating. So I thought, okay, if they can do it and they had a team, I'll try. And it's just me, but let's see what we can find. So the data that I have is from a clinical examination exam. So that means from international doctors that come to practice in Australia, they have to sit an exam to be able to practice here. And that exam has a multiple choice clinical knowledge part, but it also has a clinical structured clinical examination part where it's simulated patients, the same patient for every doctor that comes through, and there's 16 stations, so 16 different simulated patients. And what I have is a corpus of 16 videos of one of these stations. So the 16 different doctors all seeing the same patients, and you can see some of the breakdown of where these doctors came from and how long they've been practicing in the table here. So what were their instructions? They were meant to be in general practice, and their patient was a 3-year-old child who had been brought by his mother. And the child had trouble settling at night and was crying and pulling at his ears. And the doctors were meant to take a history, ask the examiner in the rooms for findings in lieu of having an actual examination of a child. There was also no child in the room, just to mention that. There was just the mother as a role player, and then explaining the management to the parent. And what did we look for? We looked for basically what was accurate versus inaccurate diagnosis. I'll get to that in a second. How long did they spend on each of these times in the consultation? So how long did they spend on the history? How long on the examination? How long on giving the diagnosis? What were the types of diagnostic statements, and what were hedges that they used in those? So types of diagnostic statements, as I mentioned before, there's some established literature already in the field, and they sort of identified 4 types of diagnostic statements that you can have. You can have a plain assertion that's not mitigated. It's basically authoritatively stating what the diagnostic conclusion is. So you have a throat infection. The second one is epistemic modality, where you are presenting a diagnosis as uncertain to a greater or lesser extent. So it's usually done through modal verbs and qualifiers and personal judgments. So including things like it could be, maybe. Then there's evidentialized, where you usually allude to the diagnostic process, so what you've seen or felt in your exam, or you explicitly describe any sort of observations. I see this, therefore it means that. Your throat is red and infected. And the last one is epidemiological generalizations, where you actually do not really say what the diagnosis is, but rather you imply or presuppose a diagnosis by sort of asserting there's a more widespread linkage to a condition of the same diagnosis that's going around, for example. So that's irritated, and the most common reason for sore throat is viral infection. It's not saying you have a viral infection, but it's alluding to that. So those are the types of diagnostic statements that we were coding for. The other thing we were looking at were hedges. So there's a lot about hedges. Here's just a tiny little list in an article on pragmatic competence and hedging by Fraser. And you can see how many there are. I've highlighted the ones that we actually looked at in detail. So looking at modals, modal adverbs, adjectives, as well as nouns, different types of words, different adverbs and adjectives. So things like probably or possibly, like, kind of, sort of, as well as introductory phrases. And those are sort of lexicalized syntactic structures that say things like, I believe, to our best knowledge, it's my view that, I think. And they oftentimes are also referred to as shields in the pragmatic literature, because they shield the attribution of what you actually meant to say. So Fraser's article looked mostly at lexicalized or verbalized hedges. So we also wanted to look at what's happening non-verbally, and we looked at the number of hesitations and false starts, as well as smiles and silences and things like that. So what did we find? And there's a bit of a picture warning coming up. So if you don't like to see semi-gross things, maybe don't look for 2 seconds. So this was the finding, and that was a picture that the candidates got shown in the exam if they wanted to do an ear examination. And that little blue thing that you can see here, that's a foreign body. So our accurate diagnosis was foreign body, and half of the doctors got that right. Half of them got it wrong. So they either said it was otitis media, so a middle ear infection, otitis externa, which is an infection of the ear canal. And one of the doctors didn't even do an ear exam. He just sort of diagnosed behavioral issues. Okay, picture warning's gone. You can have a look again. So how long did they actually spend? And that was the first really interesting thing that we found, is correct diagnosis spend a lot more time, 30 seconds more on history than the ones that ended up having incorrect diagnosis. And then the reverse was true for the actual diagnostic statements. So the ones that had correct diagnosis spend about 30 seconds less on giving the diagnosis than the one that were giving an incorrect diagnosis. And even though we're only having 16, it was slightly significant. So looking at the types of diagnostic statements that they did, we found that there was a lot of things that were evidentialized, either as the process or as specific observations that were being referred to. So as you can see here again, not a lot, but more of the doctors with the incorrect diagnosis gave evidence than the ones that had the correct diagnosis. Interestingly enough, we found that in terms of explicit acknowledgement of uncertainty, so actually really saying, I don't know, that was quite rare. And it looked to be sort of idiosyncratic, because we only found it among 2 of the 16 participants. One of them had the correct diagnosis, so their explicit acknowledgement of uncertainty was not about the actual diagnosis, but more about what the foreign body was. Whereas the one that was incorrect sort of used it, I'm not quite sure, as again, as part of sort of introductory phrasing. So it's quite interesting to see that didn't happen a lot, but a possible or potential explanation for that we thought of is probably because they're in an exam situation where they might have seen it as detrimental to say that they don't know something, and it might be different if they had been in an actual realistic, authentic interaction. I apologize if the sound's getting worse. I just had the garbage truck show up outside my house, so that might be loud. Hedges in diagnostic statements is the third big thing we looked at. So modal adverbs, adjectives, modal verbs, and regular adjectives and adverbs. And you can see there was not a lot of difference between them in terms of correct diagnosis and incorrect diagnosis. So it was things like maybe he put it inside his ear, or that could be a foreign body, or as you can see the last example about adjectives and adverbs, bit like kind of very like you know, sometimes the baby. So that was an actual thing that a doctor said, and a really indicative of that type of sort of hesitations and false starts that we had with a lot of the incorrect diagnostic ones. So a brief hard back at looking at what the incorrect diagnostic statements so far what we found. So they had longer diagnostic statements. They often provided more specific observations and evidence. And we were wondering, is this supporting evidence? Is that uncertain diagnosis? Does that signify uncertainty? And how can we link it? Is that how it's communicated implicitly? Is this an indirect way to say I'm uncertain by using evidence? So just remember that we're taking a lot longer in terms of what they were saying in giving the diagnosis. And I was fascinated when I did this analysis, and I just coded and coded. And you know, when you're done coding and you do your first sort of combination of what you've done, and it actually gives you a story that fits to what you found before, I always find that fascinating. So there were a lot more introductory phrases, a lot more hesitation, a lot more false starts for the ones that had incorrect diagnosis. So you can see that they were trying, and they had trouble to show or signify that they might not have been 100% about the diagnosis. So where did most of these things occur? Because that would be the interesting bit to see, because our hypothesis in between was, if you use hesitations or hedges to express uncertainty, is that part of expressing uncertainty as evidence? So this is an in vivo matrix cutout, and I'm just going to highlight the interesting bits. So explicating evidence is our evidentialized diagnostic statements, and that's where most of these hedges and hesitations and false starts occurred. So that makes you wonder what evidence is really worth in a diagnosis. And the best example that I probably have is this person who's pointing out he's pointing at the foreign object by saying that's his tympanic membrane, pointing directly at the bright blue foreign object in the picture. So he's using evidence while giving the wrong diagnosis. And what we found is that especially these introductory phrases that we had, so on our topic examination, I can find, I guess, I think the relevant findings, the examination of the right ear, and your history. So it's all introductory phrases that are used as hedges that actually function in using evidence as shields to signal a lack of commitment of the speaker to what they're just saying. So I think that's quite interesting to see if you look at it from the perspective that, yes, hedges and indirect expressions of uncertainty are probably the most common, as previous research has suggested, but no one's actually really looked at what kind of function they have. So there's still more for us to do. So we really want to find out what is said or hedged in a diagnostic statement. Is that indicative of diagnostic accuracy? We didn't have any data from them here to sort of find out whether the doctors themselves felt uncertain, but it's a good way to start to look at hesitations, false starts, and introductory hedges as common ways to implicitly communicate that uncertainty. And I think it's a really brilliant first step in actually getting a pragmatic look at what's happening here. So thanks for listening, and Wayne, I hope I didn't run over too much. It says 20 minutes on my PowerPoint clock.
Yes, exactly.
So. Good. And I'm happy to, obviously, to take questions or explain a bit more.
Wonderful. Thank you so much, Mary. That was really interesting. So please feel free, audience, to put a question in chat or just indicate that you've got a question in chat if you have one. And if no one wants to go first, I've got about 10 million questions. So, yeah, go ahead.
It's fascinating. You know, when I came here, one of my friends, an old gentleman actually, said to me, "Oh, you know, in Australia, the doctors are very good, but the surgeons are excellent. But diagnostically, the Australians are hopeless. You can't really rely on them." So it's very interesting perception, right? So I was really fascinated by your statement that you know, those the accurate statements are actually the doctors are spending more time. You know, it's quite an interesting finding. And my question is, so how your research can actually then inform the doctors, or you know, change their attitude actually to make a better kind of diagnostic statement if they are not so sure. I guess those doctors who are doing this uncertain statements are probably either they are really not very well trained, or they are so uncertain they are covering up their own ignorance, I guess.
I think a lot of the uncertainty that is sort of the uncertainty that's expressed through the hesitations and the false starts, that's probably actually uncertainty in trying to buy yourself time while you still think, because you either don't know what to say or how to say it, or you don't know what the actual diagnosis is. I probably have two ways to answer your question. The first one would be that the data that I have here is based on non-native English speakers. So my approach to them would probably be different to the clinician field as a whole. For the clinician field as a whole, I would say it's about awareness raising. It's about sort of figuring out when you use evidence where you may be uncertain and why you do that, and to sort of reflect. There's a lot of sort of reflective learning in medicine. For the international medical graduates, it would usually need to be two-pronged, because it's a question of social pragmatics. Do they know that they're allowed to say that they are uncertain? And then the second one is sort of the pragmalinguistics aspect of it. Do they know how to say that they're uncertain, especially if it's not their first or native language, or if they haven't ever practiced in that language? So it's more about awareness raising and showing them the different strategies that they could use to achieve these goals, and that it's okay. And that's a bigger cultural shift that needs to happen in medicine as a whole, is that it is okay to be uncertain and to express explicitly uncertainty. Because the other thing that I did mention is that a lot of these things also function as interpersonal markers to build relationships. So a lot of hedging and saying things like sort of, a lot of the times doctors use them to reduce sort of the social and power distance between doctors and patients. So because they function on so many different levels, it's unclear what the patient hears, and if to a patient that communicates uncertainty, or if to a patient that communicates rapport building or trust building. So I think that's quite protracted, and I'm still working on that.
Thank you.
Thanks.
So any other questions?
Yes. Me?
Wayan.
I just want to check. So your corpus consists of natural kind of conversation between doctors and patient, right?
No, there were video recordings in a simulated encounters that was also an exam for these doctors. So doctors often sit exams that are clinical cases where they have either a real patient or a role-playing patient. So this was a patient a role player who played the mum, and all of these were all 8 minutes long. This is why you can sort of delineate between the different stages a bit better than you could probably do in actual interactions. But there's also research on authentic data that shows that a lot of the time is spent on history taking, less time is spent on diagnosis. So that sort of aligns, but they haven't really looked at how much time is spent for correct versus incorrect diagnosis in authentic interactions.
Okay, it will be interesting to see. Oh, are you planning to do kind of, looking at real naturalistic
Yes.
data? Okay.
Yes.
Good. Thinking about this communication as, two-way between patient and the doctor, and it would
Yes.
be good to see the engagement.
Definitely.
Yeah, okay, good. Thank you.
So that's also why I didn't say anything about sort of patient responses or anything, because the patient here wasn't real in a sense, and there were probing responses that I feel a regular patient wouldn't do. So things like, oh, so he just has an ear infection. I don't think a regular patient, or most wouldn't. They would probably be like, okay, an ear infection, or say nothing, because most responses to diagnosis are nothing.
Thank you.
No worries. But yeah, really, really want some natural occurring data.
Mary, I think that the fact that it's in an exam situation, has a huge impact, and I actually think that is super interesting in itself, because it tells us a lot about the perceived construct. And as you suggested, that saying I don't know is probably dispreferred in an exam context, and I wondered even if expressing uncertainty may be perceived as dispreferred in an exam context. It might not be dispreferred, but what really matters is what the candidate thinks is dispreferred. And I'd imagine that this sort of over-detailing of the inaccurate ones is probably a similar sort of effect. But that's super interesting to me as an assessment person, because that says something about the simulation context, and that says something about how we judge who's fit for practice. So, it's just because it's not authentic. Yeah.
So they, just as an aside, they all got examiner scores as well. And the ones that failed, they all failed because the diagnosis was wrong. So in terms of communication, they were all classified as, that was good, and out of a scale of 4, with 4 being the top. They all got 3s or 4s on communication, and they fell down because they got the diagnosis wrong. It was quite interesting to see how that works on a communication level, intertwined with the error that they made.
Yeah, that's really interesting.
Happy to chat more offline.
So are there any other questions for Mary? Okay, so thanks very much, Mary, for that. It was really, really wonderful to hear what you've been up to.